Hello and a warm welcome to The Pulse, your one-stop show that gets you issues impacting the society. I'm Neelu Vyas. Through this show, we have tried to focus on areas which require introspection or focused thinking leading to solutions with the renowned experts from respective fields. I'm happy to share with you that Pulse from now on will be a weekly show on Rajya Sabha television. So let's begin today's show, which is on a growing distrust between the doctors and the patients. You saw what happened just a week ago at the NRS Medical College in Kolkata, where junior doctors were assaulted by the angry relatives of the patients, and this incident triggered protests across the country in solidarity and in demand for protection for doctors' safety. This is not just a one-city phenomenon, but a trend which is becoming rampant and widespread across the country and the globe. Why are incidents of mob violence against doctors increasing in the society? What can we do to make the doctors feel safe? Do we need a central legislative protection? And do we need a special training or a curriculum or mindset change? All this and much more with a moot question on the debate today as to who will heal the healers. Joining me now, some prominent voices in the field, Dr. Nimesh Desai, psychiatrist and qualified health professional, who is currently the director of Institute of Human Behavior and Allied Sciences. He's also worked with NIMHAS Bangalore and AIIMS. I welcome him on the program. Next to him is Dr. V.K. Tiwari. He's director and MS RML Hospital, a renowned person again. I welcome you on the program. Next to him is Bejon Mishra, founder of the Patient Safety and Access Initiative of India Foundation and Partnership for Safe Medicines. I welcome you on the program. Next to him is Amrinder Singh Malhi. He's the president of the Resident Doctors Association, AIIMS, New Delhi. I welcome you also on the program. And next to him is Dr. Harjeet Bhati, national spokesperson of the Indian Medical Association. I welcome you, gentlemen, on the program of this edition of The Pulse. And also, I welcome this beautiful audience which is joining us. And let me tell you that because we are discussing the distrust between the doctors and the patients, we thought apt to invite the resident doctors from the All India Institute of Medical Sciences and Safdarjung. So a big round of applause for these panelists who are joining us on the show and also for all of you. So let's get started with today's program. And I would like to begin with the doctors here, the young doctors who are joining us on the show. To begin with the front row, this lady here. What are actually the problems which are faced by the resident doctors for a person who actually doesn't know? Maybe, for example, in the night shifts, when patients, the trauma patients reach the hospital, no one really realizes the agony and the pain of the doctors. So what is the pain and agony? We really want to, we want you to share that moment, how difficult it gets for you when the patient arrives.
Myself, Dr. Surbi. I'm working as senior resident. The main problem we face is the long working hours and the moment the patient came into the casualty, and when we attend the patient, they don't have any patience to listen to us. They don't give us the proper history, and from there the actual lack of confidence arises.
So the patient's impatience lands you into a problem, right? Yeah. Okay, I want some more people to talk. Just pass on the mic, please. Yes.
Myself, Dr. Ashu Kumar, senior resident in Safdarjung Hospital. Main problem in casualty is the workload. Most of the residents are overburdened, and there is a much more communication gap between the doctor and the patient. And especially in higher center, patient want immediate treatment because patient think he wants immediate treatment without any lack of the time. But in higher center, it is not possible nowadays because many things hamper the treatment of the patient, like infrastructure and facilities available in government hospital. So there is a many issues which can lead to.
So you're pointing out at a lack of infrastructure, and that definitely is a factor. But I want some more people to talk before I go to Dr. Desai on this. Yes.
I am Dr. Joyatpal Biswas, senior resident in Safdarjung Hospital. Time is also one of the major concerns. We are not able to give them adequate time. Ideally, each patient should be seen for at least 20 minutes, which we are not able to due to huge burden of the patients and lack of manpower. In this way, we can see only 3 patients per hour. But what we are seeing is anywhere between 40 to 50 patients per hour in casualty as well as in busy OPD. So that is also one of the concern. What we are disseminating, the information which we are disseminating is not being perceived by the patients the way it should be. So I think there should be some counselors who can bridge the communication gap between the patients and the doctors due to this lack of time.
You made an important point, and on this I would like to go to Dr. Desai. You heard them saying, they pointed out a few problems. And I wanted to analyze this in the backdrop of what happened in Kolkata at the NRS hospital. How would you really look at this incident?
See, I'm actually totally with this group of people, my junior colleagues who spoke about their problems. But one is also with the clientele. And I was trying to make a note here. What are the issues that the hospitals and the doctors have? Workload, working hours, lack of facilities or lack of beds, particularly ventilators, and time. What are the issues that the consumers have? Immediate attention required. I want that as a right. Highest expectations of quickest recovery. You have decreasing trust in hospitals and doctors in general in the society, especially with government doctors and hospitals. And that is what translates to that frustration in the emergency room. But most importantly, as our young friend said, communication. I'm sure Bijon will bear me out. We are talking about emergency issues and the violence there. But generally, in the US and Western world, there's been very good research to say that 90 or 95% of the legal cases are because of lack of communication. And obviously, because of the factors that I listed in both the tables, the need for communication being adequate and crisp is so much more in that emergency situation.
Right.
If I might say, as 20 years of being an administrator in a government autonomous institution, one thing that I have learned for myself, and I keep trying to pass it on, is that any one of us, when one is in trouble, when one is in medical anxiety for oneself or for the family, has a locus to become illogical and high expectancy. I mean, I as a psychiatrist would say that's fine. But all parties need to recognize that there is a balancing act that's going on there.
You made a significant point, but you also said that, this distrust comes heavily when you come to the government doctors. And Dr. Tiwari, I would like to hear from you on this, that why is there a growing distrust, especially, seen in the government hospitals?
I will not agree with him because many of the patients we are getting that they are being freezed in private hospitals. So kindly admit them in your hospital because we don't rely on private hospitals. So as such, there is a mistrust on doctors, whether it's government or private. Suppose if in government hospital, they will say we want to go to private. From private, so in ICU, if they are admitted, say in corporate hospital, per day expenses will be somewhere around 1 lakh. And once, say 10 days has passed, they are not able to afford, then they will say that they are fleecing us and we want to shift over to government hospital. So it's not like that. In general, there is a growing mistrust in society against doctor, and maybe to some extent we are also responsible for that. If I remember my earlier days, when school going days, there used to be a doctor in dispensary in our, say, in locality to whom we used to go, and he used to refer us to the higher centers. So basically referral system is not there. As one of the reasons was telling us that for say minor ailments like fever, loose motions, they will come to tertiary care hospital. So there has to be a referral system so that the workload on tertiary care hospital for primary or secondary diseases can be reduced. That is more important.
And which the government is in the process of doing it, and they are trying to improve the referral systems. But Bijon, this entire concept of this, conventional concept that, doctor ek bhagwan hai.
Bilkul.
This somewhere, gets demystified totally.
You see, Neelu, what I would like to say, first of all, do not try to divide the medical profession into public and private. Do not try to divide it. Please, for heaven's sake, because all doctors are same, whether he's working for a private hospital or a public hospital. That's
I
number
think we
one.
should have a round of applause for what Bijon has said.
So that is the first thing. The second thing is, as a patient, when I go to any caregiver, any doctor, what do I expect? I expect quality care. And what is quality care? Quality care means you will give your best shot to me, and I should be convinced that at least there was somebody, and I heard from one of the young doctors that actually the burden is there, but it's a matter of process and system. See, if you have a burden and if you bring in a good quality system, even looking at 40 patients in 1 hour's time, you can do it in a very judicious manner and in a very efficient manner. You can, provided you are trained to do that. Now, there is a lack of training. There is a lack of competency in terms of understanding how to handle that. So, my short point is, you have to stress on quality, number one. Number two, quality has to be credible. Not that आप खाली एक सर्टिफिकेट दिखा दिया कि हम NABH accredited हैं और JCI accredited हैं. इस सर्टिफिकेट से हमको विश्वास नहीं है. On the ground आप पेशेंट के लिए क्या कर रहे हो? I believe that, you know. So the whole, you know, kind of backbone of quality is, how do I send back patient happy and contented? So in our country, the biggest problem is, let me tell you, एक पेशेंट के पीछे 10 आदमी आता है. क्यों आता है भाई? क्योंकि उनको ट्रस्ट नहीं है कि नर्स सही ढंग से इनको देखेंगे, या इनका कोई भी कुछ जरूरत है तो नर्स बोल देगी जाइए वो चीज लेके आइए, जाइए आप वो चीज लेके आइए, तो कोई ना कोई होना चाहिए. क्यों लेके आएंगे भाई? क्यों लेके आएंगे हम जब एक बार अस्पताल में आ गए हैं, whatever is required as a patient
Will be provided by the hospital.
should be provided by the hospital.
But it doesn't happen.
But it doesn't happen.
It doesn't happen.
So,
And on that, no, let me go to Amrinder on this. He pointed out at a lack of competence, at a lack of proficiency, because of which the patients go back dissatisfied. Do you agree? You are the president of the Resident Welfare Association. You are in the line of fire, the first point of interaction, between the patients and the hospital. So how are you really facing all this?
There is a difference between East and West. There is a difference between India, USA, UK and Australia. So you just see. First of all, I'm a cardiac radiologist right now. So first of all, before being a cardiac radiologist, I'm a radiologist. Being a radiologist, I have to see at least 145 scans, ultrasound per day. And in the USA and UK, they have to see just 7 to 10 scans per day. So quality is there. And if you don't have the quantity, if there is quantity, 145 scans per day, and regarding CT and MRI, there is list of we have to see 45 to 50 per day, and they are just seeing 4 to 5. Quality will be there, and if there is quantity, there little bit of quality will have to be hampered. So what we can do about that? So sir, thing is the infrastructure and the GDP. If in India's GDP is just 1.28 to 1.4%, we have to increase up to 3%. If we will not increase that, how you can?
नहीं, तो मेरा जो हम कहना चाहेंगे, my question is, I am also a citizen like a citizen in US. हम भले US नहीं हैं, but हम Indian हैं.
बिल्कुल.
So as an Indian, you can't treat an Indian patient as कीड़ा.
No.
Simple.
No.
Okay. So
No.
in
Will,
so one minute.
Sir,
So one minute.
कीड़ा कोई treat
One minute.
करता ही नहीं है.
One minute.
कीड़ा कोई treat करता ही नहीं है.
One minute.
Okay, I'll stop.
One minute.
Let the
Don't
doctors
use
speak.
Kira.
Okay,
No, you
let me go to
can't.
Priya.
No.
Sir,
Amrinder, just be
You
quiet.
please try to understand.
One by one.
Yes,
One by one. I'll come to you guys.
You can't differentiate. You cannot differentiate.
We can't
You
have
cannot
discussions like this, please.
differentiate. You cannot differentiate.
Bijon, let me hear the
You
doctors.
You cannot differentiate between.
Amrinder.
You cannot differentiate between an American and an Indian.
Okay.
I am also a human being, so I should be treated. You can't compromise quality by giving some
Bijon,
excuse.
let's carry forward the discussion.
The
Amrinder,
quality
just hang
cannot
on.
be compromised.
Just hang on there.
My life,
Just hang on
my
there,
life
please.
is very important for
Yes,
me.
sir.
Yes,
So
sir.
you
We know
cannot
about that.
compromise
We know about
quality of my and say that because I am getting
Okay.
so many
No,
scans,
sir.
I will
No.
not see you
No,
properly.
sir.
Bijon,
No,
okay.
I don't agree with
do
that.
like that.
Dr. Bhati, whatever the deficiencies in the system are, Indian Medical Association had submitted a draft bill in the year 2017, and there is a call for a central legislation. How do you keep the doctors safe? There are various states who have their own laws, who have their own systems, intrinsic systems, again, which are not working, and which is why there are rising incidents of mob violence against doctors. So what, according to you, is the safety net for the doctors?
No, so definitely. See, patient load is very much, we know that. Patients are like thousands of patients who are coming to the government hospital, as sir truly pointed out, communication skills. But the thing is that how we will communicate with thousands of people. Like if we see that Kolkata incidents, 200 people came to just kill that Parubaho, that is an intern. We can't say that Parubaho don't have a communication skills. He might have a very good communication skills, but who will communicate with the mob? When 100 to 200 people are standing in front of you and they are asking you either you do that treatment or we will kill you, then who will communicate them? You can communicate, a single doctor can communicate with a single person or their family. This is the communication. How we will communicate to the mob? How we will communicate to the people?
Very good. So I will take this point to the young doctors here. He's saying that who's going to communicate with the mob? Now, a doctor, is he well equipped to face a mob of 200 people? Yes.
Yes, ma'am. Myself, Sandeep Kumar, a junior resident. I am working in a private sector. सर, मैं सर की बात को पहले पॉइंट आउट करना चाहूँगा कि सर ने बोले कि 1 घंटे में 40 पेशेंट देख सकते हैं कि ट्रेनिंग का लैक होता है. मतलब इज इट पॉसिबल दैट 1 घंटे में 60 मिनट्स होता है? तो सर आप एक बार काउंट कीजिए, तो एक पेशेंट पे हम कितना मिनट देंगे? कितने मिनट देंगे? 1 मिनट एट समथिंग. इतने मिनट अगर देंगे एक पेशेंट को, तो हम तो उसमें हिस्ट्री ही नहीं ले पाएंगे. सेकेंड थिंग, डॉक्टर सिक्योरिटी. जब पेशेंट आते हैं उनके साथ इतने सारे रिलेटिव्स आते हैं, ये सब भी हैंडल करना डॉक्टर को पड़ता है. एक डॉक्टर को, क्योंकि कुछ भी होता है मेडिकल में, वो शायद डॉक्टर के पास आ जाते हैं कि आपके हॉस्पिटल में ये मेडिसिन नहीं है, ये काम नर्स काम नहीं कर रहा है, कि ये काम नहीं कर रहा है. ये सबको हैंडल करना पड़ता है, डॉक्टर को ही हैंडल करना है. मगर ये सब के लिए हम ट्रेनिंग नहीं किए हैं. इस सबको हैंडल करने के हम मेडिसिन देने के लिए ट्रेनिंग किए हैं, तो हमको ये सब भी ट्रेनिंग करना पड़ता है.
लेकिन जो लॉजिस्टिकल एक्सपेक्टेशंस है पेशेंट की, वो भी सिर्फ डॉक्टर से ही होती है.
वही तो बात है ना, सारे डॉक्टर से ही होते हैं. तो हम सारे तो हम भगवान तो नहीं, हम भी इंसान है. 2 हाथ 2 पैर ही है, 4 हाथ नहीं है हमारे पास, कि हम सब कुछ को हैंडल कर पाए. तो सेकंड थिंग, पेशेंट को गवर्नमेंट को कुछ इस तरह सेटअप बनाना चाहिए ताकि ये सारे बर्डन डॉक्टर के ऊपर नहीं है. ऑब्वियसली अगर इतने सारे बर्डन डॉक्टर के ऊपर आएगा तो कभी एक डॉक्टर इतने पेशेंट को हैंडल नहीं कर पाएगा. ये कॉमन सी थिंग है.
No, I'll go to Dr. Tiwari on this. Dr. Tiwari, these are very basic issues. That, you know, there are huge expectations from the junior doctors who are there on the duty, but the hospitals don't have medicines, they don't have doctors, they don't have enough staff, they do not have enough diagnostic machines, and the brunt has to be borne by the patients and the poor doctor who is in the line of fire. How do you really tackle this situation?
The main problem
you are
is
representing a government setup, so you'll have to do a lot of answering today on this.
The main problem is that they are right. Say, I give the example of RML Hospital. 5 years back, we were having somewhere around 2,500 patients. Our OPD was there to cope up with initially 2,000 patients. Today, we are having 8,500 patients in same OPD. So, we cannot cope up with that infrastructure. We have to build up a new infrastructure. Unfortunately, we have a landlock. We can't expand horizontally. That is a VIP hospital, and you can't go vertically also because security problems are there. So, these are the basic problems. Main problems is population. So, from where these patients they are coming? 5 years back, there were only 4,000 patients. Today, there are 8,000 patients. In 5 years, it has just doubled. And in the next 5 years, there are going to be 16,000 patients. So, our hospital is not, the infrastructure is going to collapse anytime. Same is with casualty. If you increase doctors, you increase nurses, say what will happen if you put in the saturated solution, you put more sugar, it's going to precipitate. You add 5 more doctors in that system, it's not going to work. So, infrastructure has to be developed. But the more hospitals they have to open up in periphery, that has to be answered. And state governments, they have to come up by opening more hospitals.
But yeah, Dr. Desai, you are running an autonomous institute like Institute of Human Behavior and Allied Sciences, where you have thousands of patients coming every day. What is the kind of system you have instituted at IBAS?
See, we have, like I was saying to Bijan informally, firstly, being a mental health and neuropsychiatry institution, hopefully our soft skills are a little better. General hospital crowds are unbelievable. Safdarjung, AIMS, RML Hospital. I have been to RML Hospital twice in last 6 months in the middle of the night for friends, 2 or 3 a.m. and there is not an inch of space to move. Forget patients being seen by doctors. So my two friends kind of got me wrong. See, what I was talking about was people's expectations and return fire for frustration is higher in government hospital because there is the rights कि मेरा हक है मुझे यहाँ इलाज चाहिए. Private hospital में obviously behavior अलग है. I am completely with you in principle that there need be no difference as far as management is concerned or quality is concerned. Correct. That clarified. The other thing that I must clarify is, and we have done that. We also had 2 instances in last 5 years perhaps, but there is a couple of things that we have done. See, security guards or whatever level, bouncers, if the situation is so bad, are not out of place because like he said, doctor cannot communicate every aspect. Doctors are not best communicators for mobs. I am totally with you on that. Even a sensitive example, I won't name temples, but most of the temples with huge crowds also have security and bouncers. So why are we so reluctant about having security and bouncers in the emergency of government hospitals? One doctor can communicate with one person, 2 family members. I am by no means saying that communication will solve the problems with mobs. There you need law enforcement, either by local security or by the local police. So let me clear about this.
So bouncers are not a no-no according to you. They should be there.
Absolutely. Neelu, let me tell you.
Yes,
Neelu, let me tell you. You see, my opening remark was, you have to bring in quality systems in the delivery system. Okay. How do you bring quality? You bring quality when you measure yourself. When you make yourself accountable to the system, then you bring quality. My question is, why is the crowd going to tertiary care? Because your primary health care, the so-called Mohalla clinics of Delhi government has gone for a toss. If the Mohalla clinics have gone for a toss, if the primary health centers are not functioning,
I'll come to you.
Where will that poor patient go? He has no other option but to go to the tertiary care. He has to go and stand in that crowd.
No, but
he
Delhi,
has no option.
Delhi
So let me complete.
Government boasts of its
let me close it. That's what I'm saying. People pat their own back. I am saying, we did a study in 2002 by the World Bank. What was that study? Why is there a conflict between doctors and patients? And what did it say? It said that the prime motive is that you are not giving a systemic care to the patients in terms of referrals. How can somebody go to a tertiary care without going to the primary health care? That's my first question. So if you are saying my Mohalla clinics are functioning very well, then the load in the tertiary care should have been reduced by now.
You have a point in what you're saying.
My only short point is, please, for heaven's sake, a patient is already burdened with disease. They need care. Their family members, 10, 12 of them are accompanying because they're not sure of the care. They are not sure of the care. You see, if today, let me tell you, if today my family takes me to the hospital and they know that the moment I am handed over to a nurse, everything is taken care. Everything is taken care. Then why should they be sleeping on the floor and waiting to see what is happening with me? They will go back and sleep. They don't have the trust.
Amrinder, you
They don't have the
No,
trust.
allow me to come in.
Okay.
Beyond, we have known each other for a long time, and I completely respect the theory, ideology, as well as the implementation that you try and be part of. I respect that.
What is implemented?
But let's,
Mind you, I have done models. I have done models in West
Let him
Bengal.
make his point,
Agreed,
please.
boss.
In West Bengal,
No,
and it has worked.
That West Bengal is where this happened.
So because they've gone back, because
I-
politically,
the point
they
that
have
I'm
gone
making
back
is-
to that system which they learned, but they don't want to accept
Beyond,
it.
the point that I'm making is this, and pardon me, this is not being said in jest, but in lightheartedness, but full seriousness. JFK or Dulles in Washington DC airport cannot be compared with ISBT at Anand Vihar or in Delhi.
Accept it.
One will have to have
But
that context.
for how long you will keep saying that? For
Agreed.
how long will you keep saying that?
Beyond, allow me to come in.
Yeah.
The contextualization of quality is an important concept.
Absolutely.
In theory, quality is great. Everything that
theory.
you said.
In practice.
No,
It
just
should happen.
allow him
And
to
we
make
do
his
that.
point,
We do
please.
that.
Yeah, it's
We
not
do
theory.
that. Some hospitals do that. But like I said, I'll not repeat. You cannot have JFK services at ISBT.
No, I'm not
IGI will still have. The metro will have. The Mofussil bus towns or ISBT will have its own problems.
Absolutely.
Yes, it will take decades to get there. And I do think that
No,
we
I
are
want a
getting there.
timeline. 70 years I'm waiting. I'm still waiting.
I know.
How
And
when
we
will you
don't
do it?
And we don't know how many
When
years
will
you have
you
to
do
still
it?
wait. Bijon.
But don't take it out on the doctors
No,
on
no,
duty.
I'm
Yes,
not taking it out.
that's what I was coming
That's
to.
why I said.
Amrinder,
No.
I'll come to you
That
guys.
is why I
Amrinder,
said, Dr.
Amrinder, my
Desai, that is
question to
why
you
I
is,
said,
you just heard
that is
what
why
Dr.
I
Desai said.
build
that you
that
cannot-
confidence level. That is why I said, build the confidence level.
That's valid.
My contention is, if as a patient I am confident of my care,
That's what
I
is
will not carry my family with me. Let me tell you that.
So if you're not
Sure.
confident, then that mistrust will always linger in the minds of the patients.
Correct.
So, and then till that time the trust is not there, the needle of incompetence will always point out at
Absolutely.
the doctors, especially the resident doctors.
I know,
So
the
you're in the line of fire.
case.
So
Yeah.
what do you do? What do you do about that?
First of all, we have to teach each and every patient where to go and when to go.
Okay.
First of all, if the patient is having cough, upper respiratory infection, lower respiratory infection, there is difference in that. If just patient is having cough and upper respiratory infection, you just have to go to primary health center, not to tertiary health center.
Right.
If you are coming to tertiary health center with just cough, and how the doctor will treat it? If patient is a neurosurgeon and other lots of tertiary, why the AIMS has been built? AIMS has been built just to have tertiary care center, not for these type of stuff, not to have cholecystectomy if the patient is having gallstones.
So Dr. Bhati, how do you raise this awareness level? Supposing a patient walks into the campus of AIMS, now he doesn't know कि उसका पर्चा कहाँ बनेगा, उसको OPD में किधर से जाना है, उसको वो भी नहीं पता है क्योंकि वहाँ पे वॉलंटियर्स नहीं है सिस्टम में. आप लोगों की अवेयरनेस लेवल कैसे बढ़ाओगे? सरकार आपको कभी बताती है, कभी नहीं बताती है. बहुत बार ऐसा होता है कि गांव से दूर दराज इलाकों से जो लोग आते हैं उन्हें नहीं पता इतना बड़ा कैंपस है, हमें कहाँ जाना है, हमारी दवाएं कहाँ मिलेंगी, हमारा खून की जांच कहाँ होगी, ये सब चीज़ें उन्हें नहीं पता है. ये अवेयरनेस लेवल किसका काम है बढ़ाने का?
एक तो पहली बात तो ये है कि पेशेंट जो होता है परेशान होता है, और ऐसी बात नहीं है कि सिर्फ डॉक्टर ही परेशान है, पेशेंट परेशान है. जैसे आपने स्कूल में देखा होगा ना कि पनिशमेंट के लिए दोनों हाथ ऊपर करके खड़े रहते हैं. वी हैव सीन इन हॉस्पिटल्स, बेचारे एक हाथ में एनएस पकड़ रखा है, एक हाथ में दवाई पकड़ रखी है, ऐसे खड़े हैं अपने पेशेंट के पीछे और कई कई घंटे खड़े रहते हैं. तो दे आर आल्सो फ्रस्ट्रेटेड. मीन्स आई डोंट से दैट पेशेंट इज टोटली रॉन्ग. They have lots of expectation when they came to a government hospital. They have lots of expectation, but when they see they have that expectation. But what will happen when they come to a hospital? What they see that this hospital don't have that type of facilities which must be given to him when they have traveled almost thousands of kilometers.
Correct.
Even after traveling for so many kilometers, they are not getting that type of facilities, and at that time they actually want to punish the government. And who will become the face of the government? The resident doctor.
Correct.
We become as a face of the government because they says that government means he is the government.
resident
So
doctors.
actually they are frustrated with the government, but their frustration is coming out on the resident doctor, and we are just becoming a victims of government.
On this point,
Absolutely
so
correct. Very correct.
what does a resident doctor do in a situation like this? You know that there's a crumbling infrastructure. We don't have a timeline before us as to when the systems are going to improve. You're aware of all the problems, but then also you're fighting with fire every second. How are you going to protect yourself in a situation like this? What are the things which you need? Yes.
First of all, I would like to thank this TV because you have raised this sensitive issue in this time, and because no one was taking this issue. The second thing, we are roaming around patient and doctor. The main culprit is government, because the first hand पेशेंट फेस द डॉक्टर फेस द पेशेंट एंड पेशेंट को ये लगता है
हमें सरकार को भी कल्प्रिट नहीं बोलना चाहिए. सरकार अभी भी बहुत कुछ कर रही है, इन प्रोसेस है, लेकिन हाँ अभी हमारे पास फिक्स टाइमलाइन नहीं है बताने के लिए कि कब होगा.
देखो अगर पॉलिटिकल रियलिटी है उसको हम नकार सकते हैं, बट लाइक डॉक्टर तिवारी सेड, द पॉपुलेशन, द नंबर ऑफ हॉस्पिटल्स अवेलेबल, द इंफ्रास्ट्रक्चर, देयर इज अ ग्रॉस मिसमैच.
Absolutely.
You're going to change that in 10 years.
You complete your point, then I'll go to Dr. Tiwari. Yes.
बट जो पेशेंट को लगता है कि सब कुछ उसको देगा डॉक्टर ही देगा, बट इतनी जो बड़ी बिल्डिंग है, जब उसमें जो इंफ्रास्ट्रक्चर है, दैट इज द ड्यूटी ऑफ द गवर्नमेंट. बट मेरे पास in AIMS we have a lot of skilled doctor. If we have only one ventilator, we can intubate only one child. If we would have 10 ventilator, we can intubate 10 children. अभी जब मुजफ्फरनगर में भी जो इंसिडेंट हो रहा है उसमें भी डॉक्टर को एक स्कैपगोट बना के उसमें वो किया जा रहा है, बट वहाँ पे एंटी एपिलेप्टिक ड्रग ही नहीं है कि ड्रग भी डॉक्टर घर से बना के लेके आएगा.
लेकिन मेरा सवाल ये है कि अगर अस्पताल में वेंटिलेटर्स नहीं है या मेडिसिन नहीं है, सो द इशू इज अबाउट प्रायोरिटाइजिंग. हाउ डू यू प्रायोरिटाइज देन?
But
what do you do in a situation like this of say what was happening in Kolkata or in Muzaffarnagar?
वहीं पे आके तो वो होता है ना, if we are taking one patient, then patient will come that why you are neglecting 3 other children. So that time assault start. Then the the facing person will be the doctor.
Can I come in there? What our young friend is saying, please juxtapose that with what Bijon Mishra was saying. Again, totally valid, sincere. I am a citizen, I want the best, I want prompt. Now, like he is saying, each of the family members of those 5 children who are young, each mother carries the same sentiment that Bijon personifies here.
Yes.
And say, I want it prompt, I want it best. Now, how is the hospital or the doctor going to do that to all 5?
See, my short point is, Neelu,
Yes, Dr. Bharti, tell me.
Just 1 minute. You see,
Let Dr. Bharti
thing is
complete,
that
I'll come to you.
Just we can't make this comment that we will prioritize. We will choose the patient. I will treat you and don't treat you.
can't do that.
These things we can't do in a government setup.
Dr. Bharti,
I raised-
triage is a valid
Triage is a
concept.
very yes.
Prioritization, when she says, is
I'll
only
come to you.
triage.
Definitely.
What are you talking about?
Triage is there.
Triage is a valid concept.
Definitely
Come on,
valid
boss.
concept.
You see,
But you can't use it in the OPD. You
Triage
can't use
is
it
here.
anywhere. Triage is for the extreme emergency.
I will tell you the
Yes.
one,
Yes, Aprinder.
one example. Just अभी एम्स में 14th I think 16 नाइट 1:23 पे घटना घटी कि एक पेशेंट आता है, पेशेंट उसको एंकल पे चोट लगी होती है, जस्ट सिंपल चोट लगी है, इट इज़ ए लो रिस्क केस, ठीक है. एक मेडिकल टर्म है ट्राइएज, उसमें होता है रेड जोन, येलो जोन और लो रिस्क जोन, ठीक है. जो रेड जोन होता है हाई रिस्क जोन होता है. हाई रिस्क जोन में अगर डॉक्टर ट्रीट कर रहा है पेशेंट को, ठीक है, प्रायोरिटी बनती है कि पहले रेड जोन जो है, जो हाई रिस्क जोन है, पहले उसको ट्रीट किया जाए, ना कि पहले वो जिसको जस्ट एक पट्टी करनी है उसको स्टिच करके भेजना घर पे.
Please listen where the assault happened.
It's a medical concept.
जो ये आप लेवल्स बता रहे हो, रेड जोन, येलो जोन, इन जोन्स के बारे में जो एक फ्रस्ट्रेटेड पेशेंट बाहर से आ रहा है, अपने रिलेटिव्स को लेकर आ रहा है, आप उसको कैसे बताओगे? क्या ये हॉस्पिटल की जिम्मेदारी नहीं बनती कि ये प्रायोरिटी समझाया जाए थ्रू सम डिस्प्ले, थ्रू सम?
उसमें मीडिया पर्सन का रोल आएगा, उसमें आप बता सकते हो सबको कि ये रेड जोन है, ये येलो जोन है, आप सबको आप इंटरेक्शन करो डॉक्टर से इंटरेक्शन करके आप मीडिया पर्सन बता सकता है. और एक
नो, देयर इज अ पॉइंट इन व्हाट यू आर सेइंग.
Neelu, there is a something called protocol in terms of treatment. Okay. Now, what he's explained is very well done, defined.
Right.
My contention is only, as you very rightly said, how do you expect a patient to understand all this? First of all, there is no business, as I am again repeating, there is no business of anybody, because when I go to these hospitals, let me tell you, I always use AIMS. I use government hospitals because I have trust in them. Okay, they have the best of doctors, and I salute the doctors, in AIMS who are working there. My contention is only that please allow the doctor to do their profession. Don't mix them up with administrative work. That's number one. Number one. Number two, when you talk about education and awareness building of patients, there has to be a different stream of people who should be recruited to do that work. Don't mix communication, administrative work, and other awareness building work with medical professionals. You see, so my contention is, in our country, we have repeatedly told every hospital to develop certain quality norms in their processes.
Right.
Get NABH accredited. We have brought down the level also. We have talked about entry level now. That at least भाई हम हाथ जोड़ रहे हैं, आप entry level standard पे तो आ जाइए. हम government hospital को बोल रहे हैं. वो बोलते हैं हम government है, हम क्यों उस quality देखेंगे? आप कौन है quality देखने वाले?
Dr. Tiwari, how will you standardize these protocols?
I will tell you.
Yes.
What happens, first about the ventilators and all that. Hospitals, they have norms. Say 20% beds, they have to be ventilators. We are having 10 to 20%. We are having 10% ventilators. But if you make it 100%, still you will need more ventilators.
But
then-
Dr. Tiwari, how will you
then-
handle a
No, no, no,
situation?
Neelu,
जब आप prioritization के
Neelu,
I'll come to you,
just-
John, please. How do you handle a situation where a junior doctor is working? He's working under pressure. No, hear me out what I'm saying. He's working under pressure. How does a junior doctor face a
They
situation or
cannot.
tackle a
They
situation
cannot.
like this?
They cannot.
Neelu,
They
the
cannot
answer is
handle
very
it.
simple. Listen. The answer is very simple. Medical, clinical concept of triaging or triage, whatever you call it. Out of 10 patients that I have in front of me in the emergency, and I'm not talking about disaster situations. Routine everyday emergency, it's the first duty of the doctor to prioritize, to triage. Out of these 10 patients, these 2 people need immediate attention in 10 minutes. These 3 patients require it next half an hour. The other 5 patients I will see in the second hour.
No, but Dr. Desai, how does the patient come to
I'm
know
going to
about
complete. What you said earlier, the hospitals have a duty to inform that in terms of posters,
Yes.
in terms of audiovisual information.
Exactly, that's what my point
And
was.
I'm not with Bijon when he says that don't mix up communication skills with the doctors. I think that is a whole lot of hogwash.
And these-
Doctors and health professionals have to be communicating. Obviously, it will be good if there are counselors alongside.
Allow him to speak. Allow him to
If
complete
there are
his point.
counselors alongside and security guards,
Yeah,
sure.
yeah.
But the first duty of the doctor, especially in emergency, is to communicate. Let's lighten up a little. Allow me to put it this way. What I have tried practicing is this, and think about it here and later. One of the answers is that every patient who comes to the hospital, let him or her remember if he or she has a family member who is a resident doctor. See, ask the family members of the SHOs how they work. So any family who has had a resident doctor knows the plight of the resident doctors. Let the family remember that. Much more importantly, and I'll take this liberty, my young colleagues, let every doctor, young doctor especially remember how you have felt when you went to the emergency or when you took your parent to the emergency room. Never forget that. Basic idea is if both parties can begin to understand
Empathy.
Hai na?
Empathy.
And we need to do that. There can be no
Neelu,
human
my
being.
only small thing is, like you gave examples, that I have got a cough and why the hell I landed up in a tertiary care. Because when I went to the public health system, when I went to the primary health care, I found that the buffaloes are tied up there and nobody is there. So what my contention is, where do I go with my cough otherwise? Where do I go? Can you help me, please?
So basically, you're pointing out where are the options. Yes, Dr. Bhati.
Want to say that we are talking about a huge burden, patient burden in the hospitals, and we know that the manpower, that is the doctors, were less in number, and if you go to the nurses and other support system, it is totally gone. Means everything is only dependent on the doctors, resident doctors in the hospitals. So instead of, means we are discussing about all these things like the patient attendant must have an empathy, doctor have a communication skill. This is more like civilizing a society, which will take time.
And looks
But
like a
for
theoretical concept.
It's a theoretical concept which will
Strongly
take time,
objected to.
but definitely
Practiced and practicable.
practice and
Okay,
practice
practice and
definitely.
practice.
But
No,
now,
I agree.
Don't say theory.
but now because I just want to say that if we can now focus on the security part of the hospital, which is a very important point which we have to go to that how we can secure hospitals.
Right. I want to go to the audience now, and I want to ask you that how secure do you feel as a junior doctor when you compare it with your seniors, the professors or the senior doctors? Are they equally vulnerable like you?
मैं डॉक्टर धनंजय, सीनियर एजेंट एम्स से। मैं सर से एक सवाल पूछना चाहता हूँ। इन्होंने बोला कि प्राइमरी हेल्थ केयर पे कोई सुविधाएं नहीं हैं, इसलिए लोग टर्शियरी हेल्थ केयर के जा रहे हैं। तो मैं एक क्वेश्चन है मेरा
आपका सवाल
कि
किससे?
नहीं, बीच वाले सर जो हैं से, हाँ, कि अगर प्राइमरी हेल्थ केयर पे सुविधाएं नहीं हैं तो उस किसकी जिम्मेदारी है? एक डॉक्टर की? किसकी जिम्मेदारी है वो? एक डॉक्टर की?
Let's not get into an argument. You make your point.
नहीं,
you
I'm
answer,
just questioning.
please.
इन्होंने 3 बार वो चीजें बोली, मैं उसी को पूछ रहा हूँ। वो जिम्मेदारी एक डॉक्टर की नहीं है, वो जिम्मेदारी है सरकार की। सरकार की जिम्मेदारी कि प्राइमरी हेल्थ केयर को ठीक करे, वहाँ सुविधाएं मिले ताकि मूवमेंट पेशेंट्स का दूसरी जगह ना हो। एक छोटा सा और एक और मेरी बात कंप्लीट कर दिया सर। और दूसरी चीज, वो तो प्राइमरी हेल्थ केयर की बात हुई, मैं बड़े अस्पताल की बात कर रहा हूँ। सफदरजंग हमारे सामने ही है, सफदरजंग मेडिसिन वार्ड है। आप अगर जाकर वहाँ देखोगे तो एक बेड पे 3 पेशेंट हैं, बेड पे 2, नीचे 1, एटलीस्ट 3 पेशेंट है एक बेड पे। अगर वो पेशेंट जो नीचे है फर्श पे पड़ा हुआ है उसकी मौत हो जाती है बीमारी के कारण से ही, तो उसके जो 7 अटेंडेंट हैं, 10 अटेंडेंट, 20 अटेंडेंट, उनका सबसे पहले रिएक्शन किसके ऊपर जाएगा कि मेरा पेशेंट तो बेड पे था मर गया, नीचे था मर गया, बेड नहीं मिला इसलिए मर गया.
You want to make a point?
I am Dr. Inderjit Sethi,
Yes.
not a medical doctor but a professor. I retired from university. What I want to say is the patient's responsibility is that with the first symptom, they should go to the doctor. The patient keep waiting and let the problem escalate and then go to the doctor when the doctor also is not able to do anything.
Okay.
Why the situation arose? Because they were not considerate of whatever the symptoms were, and I think in order to blame, why should you blame the doctor later that I didn't get the treatment? I think care for my body is my responsibility. Yes, the responsibility of the government is to provide you health care. I don't deny this. But somewhere we patients or we persons also have to care about our own health.
As sir has aptly pointed out that for minor ailments also like upper respiratory infection also we are heading for tertiary care just because we don't have trust in primary health care.
Not trust, it is not existing.
Sir,
It's not existing.
It can't be so.
I'm
it
telling
can't,
you,
it can't be so.
I showed you visuals. I showed you
You may show videos. You can't say primary healthcare in India is non-existent. You can't say, sir. Number one. Number one, let me complete,
We
sir.
will not be able to finish the program, please. Yes.
Primary healthcare in India is not existent. It is not so. Number one. The very field which they think is कि ये तो छोटा hospital है and to everybody their problem is the biggest in the world. So why should they go to primary? Number one. Number two, when they reach tertiary healthcare hospitals like Safdarjung or AIIMS, the doctors which they come in contact, they are known as junior doctors. So the moment the word junior comes, so तभी ये एक mistrust आ जाता है. So I would humbly appeal.
ये जो हाँ बोले.
I would humbly appeal कि रेजिडेंट डॉक्टर्स के नाम के आगे से जूनियर हटा दिया जाए क्योंकि जब जूनियर आ जाता है तो एक ट्रस्ट की बात रहती ही नहीं है.
अग्री. जो मॉब वायलेंस का जो ये फिनोमेना है, अभी हमने कोलकाता में देखा था, वेस्ट बंगाल, महाराष्ट्र, देयर लॉट ऑफ स्टेट्स वेयर देयर आर राइजिंग इंसिडेंट्स. क्या ये सिर्फ एक अर्बन फिनोमेना है या हम इन्हें इस फिनोमेना को हम गांव में भी देखते हैं? गांव की जो छोटी डिस्पेंसरीज हैं, प्राइमरी हेल्थ केयर सेंटर्स हैं, क्या ये फिनोमेना वहाँ पे भी देखने को मिल रहा है? हाँ,
रूरल में जो चल रहा है, रूरल वाले तो सीधा टर्शरी को रेफर कर देते हैं. तो दीज थिंग्स हैव बीन फेस्ड बाय टर्शरी सेंटर्स मोस्टली. आपने देखा होगा रूरल में ऑल्दो पेशेंट इज टू डॉक्टर रेशियो ज्यादा खराब है. अर्बन में इतना खराब नहीं है, दिल्ली में, मुंबई में इतना खराब नहीं है, बट फिर भी ये चीजें टर्शरी सेंटर्स में ज्यादा फेस करी गई हैं.
Yeah, I'm Dr. Leena. I'm from AIIMS, New Delhi. So the thing is, it's not only about tertiary or primary. The thing is, why we get beaten is because we are soft targets. There is no law, there is no centralized law against the security, for the security of doctors. Even there are communication lacunae even with the police officer or any other public servant, but they don't get beaten up because the on duty officers you cannot beat up, but doctors ke against koi bhi kuch maar de, nobody is there to stand up for them. Even our seniors do not stand up for us.
Doctors are soft target. On an average ये तू मैं मार पिटाई ये कितने इंसिडेंट्स होते हैं डेली बेसिस पर? ऑलमोस्ट डेली. मतलब आप जब हॉस्पिटल के उस रेड जोन में जब जाते हो, मैं उसको वॉर जोन ही बोलूंगी, तो आप जब उस वॉर जोन में जाते हो आपको पता है कि आप किसी भी समय पिट सकते हो, लेकिन आपके हाथ खाली है, आप इक्विप नहीं हो, आपके पास हेलमेट्स नहीं है, एम्युनिशन नहीं है उस चीज को.
1 year 53 incidents, no conviction.
Okay, 153 incidents, no conviction. Any other point?
Last 3 years, 1,000 cases. Last 3 years, 1,000 cases.
Last 3 years,
no
1,000
convictions.
cases of mob violence against doctors.
No conviction.
Just please hold the mic. We won't be able to catch your audio. Yes.
In Queensland, Australia, you get a jail term of 15 years for beating a public officer like a doctor in a government hospital.
Absolutely.
Also,
let me come to that.
After a heated debate or long debate, the point is why the lack of interest, investment, and intent of the government is not questioned. To paraphrase Subhash Chandra Bose on answering Bijoy sir, आप हमें 2.5% GDP का रेट दीजिए, हम आपको आयुष्मान भारत देंगे.
Okay.
But हमारी कोई सुनता नहीं, हमारी कोई नहीं सुनता.
बिल्कुल. You see, so let me come on to this here because they have really expressed very very pertinent points. Let me tell you. See, first of all, I want to tell you, we all citizens should with one voice condemn any violence against any doctor or any damage of property against any healthcare provider in the country.
Absolutely.
With one voice. There is no compromise
that's what
on
was
that.
displayed after the
So there is
Kolkata
no
incident.
compromise, number one. Number two, we must bring in a very stringent law. You know, like we have brought in Consumer Protection Act, where if supposing any damage is caused, any negligence is caused to a patient, he has to be compensated or she has to be compensated with crores of rupees if you have taken their life or something like that. So whatever it is, we have a law to protect the patient today, fortunately in our country. But Supreme Court has said that anybody found raising hand on a public servant or damaging public property, that person should be put and arrested behind bars and all money to be recovered from that person. But in our country,
I want to come with...
but in our country, let me tell you, because of our lacunae, because we as citizens are weak, we do not raise our voice.
You are absolutely correct. Somewhere down the line, everybody is questioning whether the enforcement is happening properly or not. Take the case of what happened in West Bengal. Now, West Bengal already had a law. They had the systemic things, how to deal with cases like that. But then also that incident happened.
Correct.
So can a central legislation really tackle the situation? Because even the Union Health Minister, Dr. Harshvardhan, said that let's bring in a central law, but every state is having a system. And despite that, there are incidents of mob violence which are happening. So can a law really do that? I'll come to you, sir. Let me
short point.
I'll come to you. Yes.
See, first of all, the legislature is not available to all the states. It's only on 15, 16
Few states. But wherever it is, it's not functioning
It's not
properly.
functional.
It's not being implemented.
The issue is that when it comes to the central law, the first thing is that it will create a huge awareness among the public that now the law has come and you are not supposed to hit the doctor. You are not supposed to even do a verbal abuse to the doctor because he is a public servant and he is serving at the best of his capacity. You are not supposed to push him to do beyond his capacity, which is not, he is not able to do that. So this legislature will not only provide us in a security, it will also provide in a great awareness campaign. And when we are made the draft point, in that we have highlighted this point that government must display this legislature to the different places all over the country, bring ads to the TV and media and to all places where we can create maximum awareness. Like we have seen in the villages, we have seen the posters on the walls or somewhere to tell the people that you are not supposed to hit the doctor because he is there to help you. But most of the time, like we have seen in the 2 days back in Maharshi Balmik Hospital and Poot Khurd, what happened that the emergency there closes at 4 p.m. People came at night time and they just saw that there is no one. They just totally destroyed that emergency. The mob have totally damaged that emergency. Now, if you see that there is no doctor there, but the patient attendants came, destroyed the emergency, now the other patients will not get treatment. So, now there is no doctor, the patient versus patient is coming out. So all these things requires a strong law so that the people know that they are not supposed to hit the hospitals, they are not supposed to damage the public property.
So you're saying that a strong law is the need of the hour.
Definitely.
But apart from the law, you also, when you talk about the awareness levels, Dr. Bhati, it's, I want to come to you, Amrinder, on this, that when media is projecting, cases of mob violence against the doctors, it's normally that, the doctors are projected as the faulty, in a faulty position, and they always project the patient side of the story. It always happens like that. So what do you really have to tell the media? How does media tackle a situation like this? We saw the Muzaffarnagar incident recently. What happened? The reporter walking into the ICU. So what are the kind of systemic changes? What are the kind of guidelines you would recommend for media? Because we need sensitivity at that level as well.
अभी मुजफ्फरपुर में क्या हुआ?
मुजफ्फरपुर,
पेडियाट्रिक ICU रन चल रहा था. वो जो डॉक्टर था, he is from AIIMS, right? And he wants to go there and work there, and it is his noble cause, for noble cause. अभी हुआ क्या उधर जाके कि पेडियाट्रिक ICU में एक रन कर रहा है, तो उसमें एक प्रोटोकॉल होता है कि you have to wear mask so that infection will not be transmitted to the patient. You have to wear कैप डालनी पड़ेगी, पूरा गाउन डालना पड़ेगा कि so that infection will not go. आपको फुट कवर डालना पड़ेगा, सब कुछ डालना पड़ेगा, फिर आपको अंदर जाना है. ये प्रोटोकॉल था, बट वो प्रोटोकॉल फॉलो हुआ ही नहीं और विदाउट प्रोटोकॉल उन्होंने परमिशन ली, आई डोंट नो अबाउट दैट वेदर शी हैज टेकन परमिशन और नॉट, वो अंदर चले जाते हैं, वो अंदर जाके वो जो डॉक्टर काम कर रहा है जिसने पेशेंट देखने, अगला 30 पेशेंट्स हैं, अगर 10 बेड्स हैं उसमें 3 पेशेंट डाले हुए हैं उसके ऊपर, अगर उसने ऊपर डाले हुए हैं 3 पेशेंट, उसकी पेशेंट की हेल्प ही कर रहा है, कोई नुकसान तो नहीं कर रहा, आप आज आके आप दिस इज नॉट जर्नलिज्म.
But,
this is basically not a journalism.
Right. But Dr. Tiwari, how do you deal with protocols like these? How do you tell the media that, look, these are the boundaries beyond which you cannot cross?
Usually
and then I'll come to Dr. Desai also.
As far as RML is concerned, we don't allow media person to enter inside our premises unless until proper permission is there. They can't enter inside ward even, leave this ICU. ICU, even doctors, they have to follow certain protocols. We have a security guard. 3 years back, we introduced bouncers, and after introduction of those bouncers, incidence of assault has came down. It's not absolutely zero, but it has came down.
When a medical doctor when he's doing his MBBS or other medical training, at that time, does he need a course of self-defense? Dr. Desai, what's your view?
See, the thing is, allow me to summarize. You are nearing the end of time, right? Whether we like it or not, and whether, I mean, it seems to me, pardon me for being an observer also here, like it happens in the emergency rooms, we have also had our ventilations here. In this 1 hour of episode, we have our ventilations except for the manhandling physical. We have had all arguments and all. Please recognize there is a serious problem with the overall infrastructure and health service delivery, but that also cannot be so brushed away by saying, give me time. We have a complex population and health services scenario in this country. 1. 2, there is increasing lack of trust and active mistrust for doctors. There is increasing violence in the society in general. Please recognize that. It's not only here. Surely, the current generations of junior doctors are facing the brunt of it because of this confluence of factors. There is no doubt that legislation will help. Legislation will help in a number of ways, as Dr. Said. But in addition to that, as I often say in some other context, acts by the parliament, acts do not change the social reality, actions do. And actions will have to be at the level of local hospitals and local management and state governments.
Okay. Quick pointers from all of you before we close the program. Dr. Tiwari?
Regarding security?
Yes, security of the doctors. How do you really make them feel safe?
We have a police chowki just in front of our casualty, but still incidents of violence they are occurring. Since we have put those bouncers and we have increased security, we have put CCTV cameras, we have put posters, we are having those slides and everything running throughout in our OPD that don't do these things. It's punishable, and these are the problems. So, by all these things, we have controlled it.
But unfortunately, I have not seen any data regarding the prosecution of the patient's relatives anywhere.
Our bouncers, they beat up them there only at the spot.
So there's no system to do that. There's no system to do that. Okay, Bijon, closing thoughts before we end the program.
You see, my closing thought is,
yes,
all these problems which we discussed has got solutions. And the solutions...
So one solution that you want to give today?
The very important solution is, patient is supreme. There is no compromise on quality. And we have to ensure...
So what about the vulnerability of the doctor?
So in order to address all these issues, we have... He wants to say something. You please say, because I'm getting disturbed.
After you please say. After you, I will say.
You make your point. You make your point.
You see,
on those points,
either I complete.
Yeah, you complete.
Bijon, go ahead, please.
So my short point is, there has been several pilots held in the country, in India, in West Bengal. We have done it 10 years back. That what are the solutions? The solution is very simple. That you have to engage with patients. You have to engage with patients' family. You have to engage with the community.
And that has not been happening.
And that is not happening. Not a single hospital has got a complaint redressal mechanism in place.
Okay.
Not a single hospital talks about patient care in terms of their manuals. We have done a study. We have done a study.
Excessive generalization,
You
sir.
see, so we have done a study.
I really have no time
We have done a study. No, 1 minute. We have done a study.
I have no time to take the
We have
supplementaries
done a
on
study.
this. Please. Yes.
Totally
Amrinder, you
false
have the point.
closing comment. Totally
I'm
false
talking
closing
based
comment.
on studies. I'm not
Totally
talking
false.
based on
Okay.
my
You are talking based on
So
studies.
I'll
They
get to
are
the
talking on the
studies
basis of what they are
and find
facing.
out that how many manuals are there.
Bijon,
which
you are...
Yeah.
Allah.
So you have heard yourself just now
No.
that prosecutions are being made, but no convictions happening.
No, but you are making your point.
So it's a
Bijon,
joke,
you are
man.
making your
I mean,
point.
you are making a law where the people don't get
Bijon,
convicted.
you
It's
are
a
making
joke.
you are making a point on the basis of your studies.
No, yeah,
They are
that's it.
making a point of their vulnerability on the basis of what they are facing every
That's
day.
what I'm saying.
Amrinder,
So-
I have to close
so
the show,
what-
please.
so that's what I'm also saying. So-
Amrinder, make your point. Amrinder Singh.
सर अगर 5 बाउंसर लगा दिए गए, स्पेशल सिक्योरिटी गार्ड्स लगा दिए गए, अगर 200 का मॉब आता है, 5 क्या करेंगे? 5 कुछ भी नहीं कर पाएंगे, ठीक है? सबसे पहले प्रिवेंशन इज ऑलवेज बेटर देन क्योर, राइट? हमको जो जूनियर रेजिडेंट्स हैं उनको बताना पड़ेगा, सबको बताना पड़ेगा कि अगर आपका पेशेंट इंटरेक्शन अच्छा है तो आपको कोई हार्म नहीं होगा। सबसे पहले सबसे पहले पेशेंट प्रिवेंशन इज ऑलवेज बेटर देन क्योर, ठीक है? दूसरी बात, हमको बीइंग ए डॉक्टर एक प्लेकार्ड लेके बताना पड़ेगा। जैसे एक गाड़ी लगाते हैं तो उनको पता होता है कि इस येलो लाइन के इधर गाड़ी लगानी है, इधर गाड़ी नहीं लगानी। उनको बताना पड़ेगा कि ये लॉ हैं, इनके पास, हमारे पास ये लॉ हैं। उनको प्लेकार्ड में अपने बैग में लेके चले जाओ। जब अपनी ओपीडी स्टार्ट करते हो, जब ओपीडी स्टार्ट करते हो, जब आप ओपीडी स्टार्ट करते हो, उनको बताना पड़ेगा कि आप थप्पड़ मारोगे 3 साल जाना पड़ेगा। 7 साल आप कुछ करते हो, 7 साल आप कुछ ना होगी। उनको डर रहेगा, डर है ही नहीं।
अमरिंदर, हंसी जरूर आएगी, लेकिन अमरिंदर ने एक टेम्पलेट दिया है, हाउ टू कीप योरसेल्फ सेफ। ओके, डॉक्टर भाटी, यस।
First of all, I want to tell you that there is a medical journal, world-known medical journal, Lancet, which told that the Indian doctor is at verge of breaking point. Depression, they are under stress. And today I will tell you that Indian doctors, specifically resident doctors, are so much under stress and they are so much now agitated and they are at the breaking point. So we want that law for them. Now it's not an issue of healthcare, it's an issue of law and order. Our resident doctors are either committing suicide or killed by society. So what we have to protect them, and for protection it is a law and order problem. For that we are demanding a central law.
Absolutely. And as Bijon said, that patient's care is supreme. But what one has to realize, I'm running short of time, but what one has to realize, that if the patient is vulnerable, then a doctor, especially a junior doctor who's in the line of fire, is equally vulnerable.
Absolutely.
And we have to be sensitive. Now remember, a doctor wears his or her white coat with dignity and pride, with an aim to save people's lives. And this cannot happen in the absence of trust between doctors and patients. So if patients are vulnerable, even doctors are. Remember that, at the cost of repetition. And this thread of extreme sensitivity needs to be respected by one and all. And that brings us to the end of this edition of The Pulse. You can write to us on our Facebook page. You can also send us your feedback on the email ID flashing on your screen. Thanks to all my guests, Dr. Bhati, Amrinder, Bijon, Dr. Tiwari, and Dr. Nimesh Desai. It was a pleasure having you on the program. And a big round of applause for this wonderful audience to join the show. And again, at the tail end of the program, I want to salute all the doctors who are in the line of fire. And at least Rajya Sabha TV has done its bit in saluting the doctors, and we respect you all for that. Thanks. Thanks, and be back.